Everybody has a moment of forgetting or crisis. You know, something catastrophic happens at home or whatever, and therefore in the hierarchy of things that need done, the appointment is the one that's forgotten. But what we are really interested in are the people for whom, you know, there's a sort of pattern of this. It's that whole sort of piling up of adversity and difficulty and challenge.
When you start looking at who's most at risk of missing multiple appointments, you're often talking about people who have lots of long-term health conditions, chronic health needs, often multiple chronic health needs, physical health and mental health. If you take a slightly broader view of it, you start to see that some of the causal things and some of the issues are issues that affect lots of groups who experience social exclusion, marginalisation on lots of different grounds, or who feel that healthcare isn't for them, who feel that going to an appointment isn't for them or isn't going to bring them any benefit. And sometimes that's because there are so many difficult things going on in their lives.
So for example, if somebody's experiencing homelessness, they're quite possibly being accommodated far away from where they would normally access primary health care. They might be paying up to £300 a week for that accommodation if they're in work, which then means that they maybe don't have the money to travel, which then means that they're not going to make the appointment.
The bit I suppose I'm particularly interested in is when people are missing because the way the health service is structured requires them to do something they cannot do. And I think there is a group of people who, by virtue of the relational injury that they've experienced, and the reason I use that word specifically is to almost try and benchmark it against something like a spinal injury, which is much more visible. You can see it. Whereas a relational injury you can't see, so it requires them to do things like meet people in strange buildings, go into rooms, have the door shut behind them, have somebody become interested in their vulnerable states.
There's an aspect of what I would describe as the punitive drift of social care or any care in a way, because it feels like to me that the model is very much at the moment in time the survival of the fittest. You know, people that are marginalised and kind of maybe can't fit into that type of model aren't being included. Some of them maybe they just feel not to go to the hospital because maybe the way they've been treated previously. So they feel like, I was not satisfied. Better I stay home and just continue taking the same medication.
I had seen the demise in my own local area with the advent of medical practices and health centres. I noticed one day that I no longer had a named doctor and it became kind of faceless. And then I was seeing adverts on TV that told me about the NHS hemorrhaging money, how it couldn't cope with the numbers. And it kind of almost turned me against the NHS. It became this big thing in the distance as opposed to being part of my local community. I was a wee bit, not angry, but a wee bit frustrated because I'd had a named doctor right up until I was 13, 14, and then all of a sudden it just disappeared.
Every service is designed with an ideal patient in mind. This kind of model of a person who is able to use the service exactly the way it's designed and has a completely seamless run through it. That person probably doesn't exist, but the model of that person, particularly in primary care, often is a model that excludes a lot of people. And when it excludes a lot of people, those people are placed in a sort of deficit position relative to that model.
Anybody who has kind of multiple challenges that they're facing are going to likely be asked to explain their story over and over again when they access services for help.
And I don't really like that, especially given my background and my past and my history. It's kind of difficult to tell your life story to 4 or 5 different people who have got 7.5 minutes.
If you're being misunderstood all the time, but you're also explaining yourself all the time and still being misunderstood, it's really easy to just throw the towel in.
Primary care, as well as other types of public sector organisation are set up so that There are greater and greater clinical expectations of doctors. There are organisational issues that put a brake on the ability to identify that weight that's sitting on particular individual patients.
I mean, I say this a lot, but health services are generally by and large set up by middle class healthy people.
There was a really interesting paper published in 1971 by a chap called Julian Tudor Hart, who described a thing called the inverse care law. And in the paper he had this lovely phrase where he sort of says, some people seem to know how to make use of the health service better than others, but doesn't really get into why that might be.
Quite often historically, research in health has been really focused on biomedical, clinically focused aspects of care. So even if you think about the way sort of the media tends to represent health, it's often about the hospitals, it's often about the next fancy shiny intervention that's going to save lots of lives. And I'm not saying that's not important, that is really important, but it's got to be balanced with the sort of elements of the system that actually enable things to happen.
On the letter I've got from my specialist liver clinic, it tells me exactly how much that missed appointment's going to cost the NHS, in bold.
How organisations, not I think through any deliberate malevolence or anything other than unconscious processes, end up actively excluding people from healthcare because the person is not relating to healthcare in the way that we have set the healthcare system up.
So that's one of the reasons why bringing experts by experience into the frame are really important.
I think where structural competency comes in is, yes, you need to listen to the needs of individual patients to have an understanding of their circumstances, but it's also about a more structural understanding, a more political understanding of how the world operates.
As a health service, what we are focused on is outcomes for people. So we're wanting everybody to live healthy, long, fulfilling lives. And the problem I have is that it's far too much focused on the majority, and it's not focused on the groups of people who die early, who end up really ill really early, and who services don't meet their needs.
We're very good at locating the problem into sometimes the most vulnerable members of society. They didn't turn up. What we're not so good at is then reflecting on the disappointment and thinking about whether it might tell us something about how we are set ourselves up.
I think people could quite easily perceive it as you're not there, therefore you don't care, and not understand that actually it's not about personal choice. Even if some of the research can help us to be able to articulate that a bit better, that for me would be really, really great.
Working as a clinician in inclusion health, I was always struck by how people were often excluded from the system, and then I got involved with a project called GPs at the Deep End, which was a sort of group of GPs who work in the most socioeconomically deprived communities in Scotland. And when we all got together, it really quickly became evident that the sort of issues that we were trying to grapple with as day-to-day clinicians in inclusion health, actually mainstream Deep End practices were doing the same. And that got me thinking. Initially, actually, we went to some funders and said, we want to look at developing some interventions, and the funders basically said, this isn't an issue. So it was invisible at the sort of research and policy level as well. So that really started us on this journey where we then managed to get funding and undertook epidemiological work, looked at over 500,000 patients' records from across lots of different practices in the country. And when we pulled all of that together, we were actually a bit shocked. We thought it wouldn't be great. We thought people would maybe have poor outcomes, but actually people had lots of health conditions. Death outcomes were really high, particularly for people who have mental health diagnoses in their GP records. The important thing though about research is that, it doesn't take place in a vacuum, and we as a team need to be thinking already, how can we be ensuring that policy and practice colleagues hearing about this work are open to thinking about the solutions, and across the team we've got good relationships with a range of colleagues. So I'm Andrea Williamson. I'm a GP by background and I'm Professor of General Practice and Inclusion Health here at the University of Glasgow. I combine research, teaching and clinical practice. I'm the lead for the project. Professor Kate O'Donnell is the co-principal investigator. She's a very experienced researcher who's done lots of intervention, development and evaluation, and also has a particular interest in migrant health.
My name's Callum. I'm a research associate here on the Missingness project. My role primarily is looking at the existing research around why people miss multiple health appointments. I'm qualified as a social worker and worked a lot in third sector organisations around migration, around supporting people who recently arrived. What the project leaders were looking for were people to bring a sort of sociological perspective on things. So I think what I can bring is a bit of that.
You also have David Ellis on the project, one of the co-investigators on the epidemiological work about multiple missed appointments in the NHS in Scotland. His expertise really is around big data and the open science approach that we're taking to this work. And then we invited Dr. Jeff Wong, one of the world leaders in realist synthesis. He's also from a GP background. He challenges us and some of our assumptions. And then we have Professor Vary McKenzie, who's from a social science background.
I'm Vary McKenzie. I'm Professor of Public Policy here in Urban Studies, which is part of the School of Social and Political Sciences at the University of Glasgow. My work has involved talking to policymakers, to practitioners, members of the public about how they understand health inequalities. And the reason for doing that is to shape policy differently.
I'm David Barafati. I'm working in Work Programme 2, setting up and undertaking most of the qualitative interviews. I've worked at the Scottish Government doing research in the drugs department. I was previously doing a PhD on health inequalities with Vary McKenzie.
And then we have Professor Sharon Simpson, who's helping us out with Work Package 3, which is Interventions Development, which is a series of workshops. So she comes from a public health and interventions development background.
It's a kind of cross-section of people who are GPs, kind of academic GPs, whether it's in inclusion health or whether it's in general practice more widely. One of our co-investigators isn't an academic at all.
My name is Michelle Major. I'm an impact lead at Homeless Network Scotland. So I lead on involving people with lived experience of homelessness and designing policy and kind of helping decision makers and government.
It helps to shape the project in a way that makes sure it doesn't run too far down in any particular direction.
So Elspeth Ray is the project administrator. She is trauma-informed, flexible, and she's just able to basically embody all of the principles of the project. As I've kind of gone on in my career, I think I've become reasonably well known for taking a sort of social justice approach to health. You know, the reason that I choose to spend some of my working week in research is because I want it to make a difference. I want things to be different in the NHS. What we want to do is to come up with a robust bit of research that says, you know, here's what the problem is and here's what we think a recipe would look like for how we provide solutions. What we're trying to do is we're actually trying to think, what do missed appointments mean? What does this pattern of missingness mean? And what can we pull in from other literature areas that will tell us more about it and help us think about what the interventions might look like?
We're using a model called the candidacy framework.
What it was originally designed to do was to understand inequalities in the access to services and the utilisation of services once you have accessed them.
So it's this idea that there are various points throughout somebody's journey to a service and also through a service that are potential areas where barriers might come up and blockers might happen.
It helps us to understand structural factors. It helps us to understand the way in which different policy domains come together.
It focuses on the interaction between people and services. So we're not talking exclusively about problems for patients or potential patients, and we're not talking solely about services, but we're talking about what happens when those two things meet. But the focus for us is kind of in the patient experience because we're talking about the outcomes for patients. If you think about your problem as this is an issue for services, it costs money, then your interventions are designed to save money or get money back. If your problem is patients can't make it to their appointments, they're getting more unwell, they're feeling more excluded from services, then your priority for your interventions is to tackle that.
Work Package 1 is an attempt to understand what the literature tells us about missingness.
You look at what's been written and you kind of look at how it's been written, but you also take quite a critical view of what's not been written, what perspectives aren't there.
What we're having to do is look across literatures to do with different kinds of vulnerabilities. There isn't a defined body of literature that talks to us about why people miss multiple appointments. Work Package 2 is where we fill in some of the gaps by talking to experts by experience, and we also talk to professionals who have roles in supporting vulnerable populations. And we try to understand what creates the conditions for missingness. The third work package, we continue to refine our understanding by taking our findings back to the kinds of people that we've spoken to in Work Package 2 to try and co-produce a set of interventions.
I would hope that we come out of it with a really good understanding of what is actually going on that results in people missing appointments, and that should hopefully feed into policy, practice, innovations, changes.
You know, even by taking part in this research, particularly professionals, I think they'll be going away thinking, right, okay, let's think about this. The research papers that we publish, we hope will have impacts in terms of other researchers thinking about it, but also we hope policy people will pick up on it. We are trying to use innovative methods that will help people understand what the evidence tells us and therefore help people think about what could be done in their setting.
A lot of the papers that you read make the argument around what's cost effective. Is the price of sending a text cheaper than somebody missing an appointment? And there is a reluctance to accept that the services have a degree of responsibility.
There's actually very little work from the patient or the service user's perspective about missingness in healthcare, and also professionals haven't really been asked about this.
If you're only working from the literature and you just build on that, then what you get is a flawed perspective.
Now I've done about 13 interviews with professionals, which is coming up for halfway, and 6 with people who have experience of missing multiple appointments before. One of the challenges we've been finding so far is actually getting organisations involved, just given the pressures on organisations, resource-wise, staff time, higher caseloads than ever.
I don't want to push the agenda for where things go. Vary and David will make that call. They'll go, here's the gap, you really need to try and interview somebody with X perspective.
I actually am a member of Vox, which is they produce a newsletter, and they were looking for participants on the project, and I felt keen to get involved because of service providers not producing reasonable adjustments for likes of me to be able to participate in a kind of a level playing field.
The reason we get people who are already involved with organisations, just make sure they've got the support. People are speaking about difficult times in their lives, for example, then they've got fallback support from whatever organisation they're involved with.
My reasons for doing it was based on my experience and why I missed appointments and why people missed appointments through stigma. People missed appointments for the crisis point that they'd phoned the appointment was now past. So of course I wanted to be interviewed by David.
Resource and time basically is the factor here. It takes resource and time basically to follow up people and to put in place the kind of follow-up interventions that need to be put in to help bring some people back in.
When we designed the stakeholder group, we did want to make sure it was going to be as accessible to people as possible, and that meant making kind of general decisions about how it was going to run, but also having conversations with people about what was going to be easier for them.
We were wanting to try and just sort of create a kind of level playing field where then people would feel able to talk openly and honestly about what their life experiences have been. And one of the things that we did right from the start was we didn't let anybody say anything about their background. We asked them to say their name and we asked them to talk about something like, how was your journey to get here?
When I came to the Clarence Pierce building that we're in the now, I was absolutely terrified. But I like that, sitting with people who I think know more than me. That way I can learn.
When someone is discussing the way he's seeing, I was learning. When we are brainstorming, my brain is active and I'm able to take the points that will help me in future as well.
So I came in at fair perspective of, I'll just try and soak up as much of this as possible. I'll speak to other people about their experiences in their towns and villages, because we had them for all of Britain, sure.
We had a really good opportunity because it wasn't just patients. There was a GP, there was a service manager, and we were all learning from one another.
So it kind of done that for me and stopped me from becoming angry at Easterhouse Health Centre.
Whilst it's uncomfortable for me, it's not great to be a practitioner or a nurse because they're not able to fulfil and to be able to then carry out what they came into the profession to do.
We were talking about the doctor maybe sending emails to remind the people, ask their preference, what do they want most to be communicated. Also, if they can be like an independent bodies to check how people are missing their appointments and to help do the follow-ups.
The feedback that we got from our stakeholders was that it didn't account for one really specific thing, and it was how people understand themselves in relation to their health, but also understand themselves in relation to the services and the resources around them, the communities, families that they're in. The way we phrased it in the study is that sense that something is not for me. And I think what we've been able to provide is a window a little bit into that process.
Even getting down here, there's like a phenomenal amount of energy and issues that I have, and the team, having spent time speaking to me and looking at some of the things, they've put in so many adjustments, so many basically care, to the point that I could contribute. And I think much of that, if that could be replicated in terms of what we're going through in terms of the accessing services.
I think when you show that willingness to ask people about what it is that they need and then to put in place the kind of things that are going to help overcome those things, not only does it have the instrumental benefit, but it has a relational benefit as well. You actually demonstrate that you can be trusted to follow through, that you actually are caring about someone's input and facilitating that input and maximising that input.
When I came, I thought it was the possibility for change. I thought that we could have some sort of say in how that change was going to happen. I came here with that view. I've got something to say about this, let's do it.
I've worked in the NHS for 30 years now. I'm aware that you get successes with some things and then there's some setbacks, and so we've done all this work, we've done all this research effort, we've produced papers, we're going to be producing videos and things. We can't entirely predict where this is going to travel to, but we've, to the best of our ability, tried to represent people's views.
I have the view that what I says was took and shaped in such a way that it didn't sound like it was coming from me. The academics might not use that same language. It might look like something else, but basically it's what you said. And for me, my truth is the truth. Whether I know that's real or imagined, it's still my truth.
At its very core is a question about if anyone has the right to speak for somebody else and to take someone else's words, interpret them and kind of put them out there in the world. And I think if you start with that, it's really important. When I've worked on taking the stakeholder data, there is just such a vast amount, and every single time you cut it down, what you essentially do is you take people's actual words out of it and you summarise them. And I think something really important is lost in that a lot of the time. And I think when it comes to actually sharing the output, having people's words stand for themselves is really important. And ideally what we want to do is take the transcripts and make those transcripts of interviews, once they've been anonymised and once they've been kind of cross-checked, available.
I get the feeling that they didn't want it to be about individual stories either. They wanted to look at it as a whole. If you're going to come to me and ask me, I couldn't give you the view of my scheme. And academics have got a way of saying, right, okay, we'll use that, but we'll broaden that out and we'll take that as the census of that area.
I think understanding that it's all co-created is a big part of it, and actually putting that out there when you communicate it and saying, this is the process that we went to get to this. We feel that it is a fairly good reflection of the world as we found it and as it's been communicated to us. And these are the steps that we've taken as researchers and as authors to gather the data, to manage the data, to interpret it.
After doing the missingness stuff with the university, it became more holistic. It became more about looking at the bigger picture as opposed to only the experience that I had with missing appointments.
It made me feel more responsible, more accountable for others. Some of the aspects were so empowering. It took me out of my comfort zone, but it made me feel, right, okay, I wasn't alone.
We've set out to answer quite a difficult question, and I think we thought about how to do a lot of those things just slightly differently, just by making things a bit more accessible, just by changing the approach a little bit, just by bringing in different voices and different perspectives.
Being part of a collective and a group that are hopefully moving towards a better understanding of missingness and why people do what they do and why the NHS is in the state that it's in right now.
I think the awareness is still probably the biggest thing about this project. Getting a shared language to articulate and start to describe some of the variables that serve to keep people missing, and then taking it round our leaders.
It does really feel like we have managed as a team to make something visible. So many colleagues saying, yep, this has articulated what we've all been experiencing, either as professionals, as clinicians or people in the third sector, or as patients.
That group's galvanised, I think, a movement. Yes, it might have just been an academic exercise, It will be reliant on governments, it will be reliant on, practitioners, but it sowed the seed for change and validation.
What I will probably take forward from this is any research work that I do going forwards. I would like to hope it would have the same kind of shape in terms of the stakeholder input, because I think that work that I've done in the past has been limited by the absence of the level of stakeholder input and the variety of stakeholder input that we've done.
If you're going to try and evoke change, you need to go where it's needed most. You need to see why people do what they do.
Sometimes people do have, whether it's because of past experiences with healthcare systems or with research or whatever, a really natural degree of skepticism, uncertainty, feeling like things are perhaps being overpromised.
You're asking us for our time, and you're paying us for that, by the way. It's like you're not asking it for free, you're actually paying me for it. Then listen to what we've got to say and allow us to take part in it in a meaningful way.
Has no guarantees over what will happen next. I or the team or anybody else is involved in the work, we've done the best we can with the tools that we have in terms of trying to make this as best quality research it can be, trying to use all our connections at policy and practice level to really push the message of this work forward.
Don't let's get lost in the language that you're using. Let us keep it as simple as possible so that both people can understand what we're saying.
Policy language and policy stuff is all the time often feels like a performance. And so there's a level of what people are kind of expecting to hear, the kind of language that is expected.
Because not only are we speaking to the people who are involved in the money part of this, we're also involved in speaking to the people who are actively doing this on a regular basis. Forgotten people, missing people.
Ultimately, what we would like to see is people feeling that the health service is for them. It's designed for them in mind and gives them the things that they need.
It should be for everyone, and I think we can achieve that, but we need the willingness and the people to say, yeah, we can do it. Again, get back to this person-centred, holistic, tailored approach.
I think this project has a good chance to do that.
At the moment, we've had conversations with the people that actually decide primary care policy. And really importantly, we've also had conversations with the third sector. We've had conversations with people across the Royal Colleges, we've had conversations with the Chief Medical Officer. At that level of policy, then people in all sorts of different areas then pay attention.
We're at a point now where people are receptive, And I'd like to think that this research will play a pretty big part in getting those resources to people to make those changes. What we have designed ultimately is a suite of interventions. An intervention essentially involves making a change somewhere within the system that's going to have an impact on the outcome that we want.
It needs to be targeted at groups who have the worst outcomes at the moment, who have the sort of highest rates of missingness.
Each part of it is kind of an essential part of the whole. Put together, they kind of mutually reinforce each other. It's about more than the kind of technical solutions that we tend to see, reminders, booking systems, and increasingly artificial intelligence and predictive systems. And it's about bringing back a kind of relational understanding that this is care that we're talking about. It's about bringing some of the psychology back into it and understanding that often people don't feel safe in the healthcare environment.
The really fundamental first thing we're wanting to do is to change people's opinions about what missingness means. And that's what we're calling applying a missingness lens, and there's a whole series of components to that.
Understanding what missingness looks like at a local level, whether it's for individual patients or within the kind of service system. Changing that perspective from a more kind of punitive and restrictive sense to something that's more supportive and positive and invitational, trying to bring people back into care, and ensuring that service systems are able to help staff to do that with the resources and the means and the support to make those kinds of changes.
Applying a missingness lens is a tangible way to achieve health equity in the NHS. You know, something that has been an ambition in the NHS across the UK for decades now. After that, what we need to get a lot better at, because we're terrible at it just now, is actually identifying patients at risk of missingness. That's not done at the moment.
That means identifying the individual patients who are missing or who are most at risk of missingness, what's happening for those patients individually and assessing their kind of needs, taking those individual assessments and building a broader picture and a practice for the kinds of things that might be sustaining missingness more broadly. The third kind of fundamental element is missingness coordinator. In the stakeholder group we had missingness worker, and that is essentially somebody whose role it is to not only work with patients individually to address the causes of missingness in their lives, and that might be within the health service, but it might also be broader needs.
At a macro level, it might be that that person's job is to look at an individual practice or a cluster of practices or a hospital and say, right, okay, what at the moment are the big drivers of missingness for the patients that come here, and what do we need to do as a service to change that? They're the sort of three big ticket ones, and then within that we've got the sort of whole focus on relationships. Relationships and communication, and kinds of changes that are going to help build relationships of trust and often rebuild what are broken relationships for people with care, with the health service, with services more generally. That can be really instrumental things like ensuring people's communicative needs are met, and that can also mean training staff and providing staff support in trauma-informed practice, in patient-centred approaches, collaborative care, and I would say that is a kind of really fundamental cross-cutting theme. Every contact with the health service needs to be rooted in the principles of good communication. Contact around appointments means contact before an appointment that might have a reminding function, but might also be about helping somebody feel safe, reducing their anxiety, identifying and addressing some of the barriers they might have to access. But also it means making contact with people afterwards, taking that very welcoming, invitational approach so that people are inclined to come back again and inclined to start attending those appointments. Another big factor is thinking about transport and logistics. Our stakeholder group talked a lot about the different transport options that are available. That might be reimbursing bus tickets, providing bus passes or train passes. It might even mean that they need somebody to accompany them to appointments, so that might be part of the role where the missingness coordinator would come in. It might mean reducing the need to travel completely through home visits, telephone appointments, video appointments, practices and practitioners going out into the world, into other services to provide care, and actually taking those steps to get out to people rather than asking people to come in. Or if you are asking them to come in, making sure that their needs are addressed and doing it in a way that's very inclusive. The current system of primary care
is quite rigid. It has very specific rules for access. And so when we talk about flexibilities, that might mean allowing people to drop in. It might mean providing people with a kind of open time at which they can come in rather than a specific appointment time. Prioritising them for more rapid appointments, giving them the means to make appointments in different ways. All those kinds of things that mean that things become more accessible and more flexible to their particular living circumstances. I think we have the tools and the knowledge, the information that's required to make a meaningful change in how healthcare is delivered.
Basically, GPs need funded to identify patients, have some level of missingness coordination in their practices, and then actually across the whole NHS there needs to be missingness coordinators and there needs to be core action taken.
I think we have a level of interest from people who have the power to make those kinds of changes. We have an opportunity at this particular point in time for those changes to actually happen.
It helps policy makers and practitioners, like there is actually a strong evidence base that underpins. So we're really keen to see the suite of interventions that we have pulled together actually turn into action in the real world. But that is quite a big ticket because we know how badly underfunded GP practices are generally at the moment, but specifically in the deep end. They are, proportionately underfunded, so the catch up is even greater. But I'm relatively optimistic that will change.